OsteoSignal episode 27. This is OsteoSignal with Neal D. O'Neill, a podcast exploring how your body's natural design connects with osteopathic science, translating complex signals into practical insights so you can truly thrive.
Okay, where manual therapy and movement enter the system. I want to bring this back to what we actually do as manual physical therapists or as manual osteopathic therapists, because it would be easy to hear all of this biochemistry and conclude that we're just waiting for someone else to fix the iron before we can contribute, and that's not the right frame. Manual therapy and movement have direct physiological effects on this system. Mechanical stimulation of connective tissue activates mechanoreceptors that send afferent signals to the brainstem, specifically to the nucleus tractus solitarius and the other vagal nuclei, vagal regulatory nuclei. Mechanotransduction, the conversion of physical force into cellular signaling. Maybe make a note around that one, as I use that term a lot. The conversion of physical force into cellular signaling and neurological signaling can directly shift autonomic balance towards parasympathetic dominance. And that's not a theory, that's supported by heart rate variability data. So we know this, we've done this, we have proof of that. There's also nitric oxide dimension. The mechanical loading of connective tissue stimulates nitric oxide production by fibroblasts and endothelial cells. Nitric oxide dilates the microvasculature that feeds ligaments, fascia, and connective tissue structures with notoriously poor direct blood supply. That's helpful. In a patient with low iron, improving local perfusion, even modestly, helps the iron that is present get where it's needed and help that tissue heal. And movement itself is an anti-inflammatory signal. Exercise reduces systemic inflammation, which lowers hepcidin, the hormone that traps iron in storage cells, as we've said in previous podcasts, which improves iron availability for all the downstream systems we've talked about. Movement is not just structural remodeling. It is biochemical regulation. The mechanical input is simultaneously a metabolic input. Very important. You may have seen in recent news articles that just doing heel raises, even when you're sitting at the dinner table, can reduce your blood sugar by 10, 20, 30 points, which can be enough to keep you in range.
Yeah, even the smallest things have a huge impact.
Exactly. The treatment we're providing is actually working on the iron problem, not just the tissue problem, right? Indirectly. We're not administering iron. That's where we need them to go to their physician or go to their whomever it is they're going to do their at-home test, whatever they're going to do to figure out what their levels are and then what they need. But we're changing the conditions under which the body uses and distributes whatever iron it has. We're improving the signaling environment. And when the patient's physician is also addressing the ferritin directly, that's when you get sustained change rather than temporary relief. The manual therapy creates the window. The biochemistry has to be able to walk through that window and provide the substrate to the patient. Okay, so the clinical profile, who to watch for? Let me describe the clinical picture because pattern recognition is what makes this useful. These patients don't present as acutely ill. They're often high functioning on the outside. They've tried things. They're disciplined. They've done various things to try and keep themselves on task. It's just that they find it becoming harder and harder to do so. And when they come to you, the tissue picture doesn't match an injury. There's no mechanism. There's a diffuse, chronic, confusing, metabolic-looking presentation instead. Fatigue that doesn't resolve with rest, low dopamine drive, and neuronal mitochondrial depletion. Right, the neurons themselves do not have the energy stores produced by their mitochondria to do the work that those neurons need to do. They're wired, but they're unable to relax. They are in sympathetic dominance with impaired vagal tone. And again, that vagal tone, you can't just tap your way out of that and say, oh, I'll do this or do that for my vagus. I'll inhibit my sympathetics by laying on the foam roller. It just doesn't, it's temporarily like 5 minutes effective, but it doesn't last. It doesn't get them out of this hole they're in. Restless legs disrupting sleep, brain iron deficiency in the substantia nigra, poor exercise motivation, reduced dopamine in the basal ganglia, or reduced sensitivity to the dopamine. Right? It doesn't have to be. So sometimes we've even they've done testing where they've shown the person may actually have the correct amounts of dopamine, but they can't use the dopamine. Part of the answer. Afternoon cognitive wall, that's a big one. That is a central fatigue pattern. Chronic TART findings or tissue texture findings, particularly in the upper cervical and cranial base. Autonomic regulatory anatomy is under biochemical stress, right? They're going to have that. They'll even have they'll come home rubbing the back of their head going, oh, it's just so stiff and tight. I really want that to move. The palpatory picture in these patients tends towards chronic throughout, cool, dense, poorly differentiated tissue, right? It's hard to tell, like, where does the muscle begin and the tendon end, or the fascia begin and the muscle end? Or where does this become when does this ligament become a capsule or a bone? It's very boggy and restricted motion with a leathery or unyielding quality rather than the springy resistance you get in an acute dysfunction or normal function. Asymmetry that's been there long enough that the patient doesn't even register it anymore. They don't realize that their posture is so poor, particularly in the cranial base, right? They'll have that forward head posture, cranial base, upper cervical, and their thoracolumbar regions, right? They'll have that hump at the cervical-thoracic junction. That's all autonomic regulatory anatomy, right? The sympathetic nervous system lives from T1, usually the most outward protruding spinous process in the back there, all the way down to the bottom of the ribs, just below that. When you're palpating that picture and the history includes the pattern we've described today, the clinical flag is ferritin, specifically ordered, not inferred from hemoglobin. Hemoglobin's not going to change in time to show you this. And for years, I have a patient, I helped lead her through this, and her physician saw that and was, at first was a little reluctant, and then she kind of explained everything to her, and the doctor was like, yeah, okay, let's look at that. And she got her ferritin checked, and sure enough, the doctor was like, oh, this has been going on a long time. So with the understanding that a result flagged normal at 20 or 25 nanograms per milliliter may be functionally insufficient for the brain by a very, very wide margin. So if they show those brain symptoms, that chronic central fatigue pattern of afternoon cognitive wall, poor exercise motivation, poor motivation, inability to really get themselves up and going, that's exactly what we're talking about. The brain may need a lot more iron available to it. So it's not going to show, the periphery is not going to show the problem as soon as the central nervous system is. Central nervous system is highly metabolic. We know that.
Yeah.
So that's understandable, right? Like, oh, gee, why didn't we
Yes.
know this? Right.
And I was just thinking that too. Like, I mean, and not to take it off in a tangent, but head injury patients, concussions, my gosh, right?
Very important. Yeah.
You and I both had those athletes that you're like, they just get hammered, and especially the young ones, they're still, the brain's trying to grow, and this has got to be just a huge leak of
Right.
them being able to get
Because
better.
don't they hit cognitive wall within 20 minutes?
Yes. Yep.
So I think here we've had a couple of people that we've talked about. We had the, let's see, the moms, the postpartum. I think that was kind of a aha moment for us to go, oh my gosh, postpartum, this totally sounds like them. So certainly that's a brain aspect of this. The head injury, traumatic brain injury, even long COVID, things like that. I definitely think we're going to see that because of the bleeding of COVID. Let's say, and then like our total knee patient that we were talking about earlier, where really the answer was to get him that sleep and he had a chronic tendinopathy, and he was complaining about this and complaining about that. And really it was getting those labs and getting his doctor to see, like, oh, wait, your ferritin's not where it's supposed to be, and you're just not coming back. I mean, he had some bleeding and then loss of blood and et cetera, et cetera. And so, depending on how bad their surgery is, and his surgery was pretty rough, or they've had multiples in a row, right? Often people do that where now they have a bad hip and a bad knee, or two bad knees or whatever. So one year they have one hip or knee, and the next year they have the next hip or knee, and then they had the shoulder surgery, and then they're going, I don't understand why I'm having so many problems. And nobody's really, you have to have one doctor doing this and one doctor doing that and one doctor doing the shoulder, and nobody's really doing that overview. Like, let's see the total picture here. And that's osteopathic thinking. That's what sets us apart from other people, and how you really help people. Because sometimes in the medical system, just the way that it works with insurance and everything else, you don't have that person that really gets that overview. Everybody's overworked. Everybody's stressed. Everybody's got numbers they got to make, particularly in the hospital-based systems and this, that, the other. So it can be really difficult for patients to get the healthcare that they really need and want, the health delivery that they need and want. And it's not always just that it's a bad doc. The doc can be great. They could just be overworked, or they just missed it. And that's why we're part of the healthcare team, and we think this way and help lead patients through this. So,
Well, in a lot of cases, maybe we've missed it for a long time too.
sure.
And now that we're becoming more aware of it, so we're all trying to work as a team and just help the patient get the care they need and help the doctors shine. I mean, they do this, they have the means to be able to administer what we can't. And so if we can help kind of push them through there, then everybody gets help and everybody does what they do best. So it's great.
Exactly. So before I do the full conclusion here, I do want to say the things that we can do while we're waiting for the iron transfusion or whatever to take place. I mean, certainly remember chronic inflammation. And that's something that we as osteopathic manual therapists, that's what we do. Chronic inflammation. The liver makes the hepcidin that in chronic inflammation locks the iron in the ferritin. So again, we can treat the liver, getting the liver not to be inflamed. So many people are on an edge of fatty liver syndrome, right? Alcoholic, non-alcoholic. There's all sorts of things going on. People are challenged, making sure that liver is not putting out hepcidin when really the inflammation's in the liver and maybe not through the rest of the body. Now, here's where treating the duodenum, right? Iron metabolism is a tightly regulated process of absorption, transportation, utilization, and recycling, mainly to produce hemoglobin, but these other things. It's absorbed in the duodenum. Is the duodenum inflamed? So can they not absorb that iron, right? I mean, that's knowing where it's absorbed. That's early on in the foregut to midgut. So that area has to be treated. And people that say I have that bloating, right? That's now macrophages recycle that. So making sure that the sympathetic nervous system's on high so that the macrophages function properly. And like I said, hepcidin, a liver hormone, controls the homeostasis by inhibiting iron release in the blood. Let's get the liver calmed down and decrease the hepcidin production. So those are all a big part of what we do, making sure the diaphragm works, making sure that oxygenation is appropriate so that you can cleave iron. So you can see what it is we do. We're doing our part. Make sure that you don't have inflammation in bones or stiff bones so that when particularly the ribs, which is where iron is turned into red blood cells, et cetera, et cetera. So, and where macrophages can come from. So we need to look at all those things, right? And that's what we do as osteopathic manual therapists. We'll work on those other things to maximize what the patient has and help that patient integrate as soon as they do get iron coming in, help them absorb it through nutrition, help them use what comes in through infusion or otherwise. So that's where we come in. So just to recap here, iron in the brain, dopamine synthesis, rate limited by tyrosine hydroxylase, a rate limited by iron. Central fatigue when neuronal mitochondria can't sustain output. Vagal tone impaired when the brainstem nuclei that generate it are under-resourced. Sleep architecture fractured. Glymphatic clearance incomplete. And through all of it, hemoglobin is normal, TSH is normal, everything's fine. Hey, just eat a little extra, make sure you get good nutrition. That's not the best advice we can always give. And not blaming the doctors, just saying we all need to be part of the healthcare team and help educate patients, educate ourselves about how can we be part of that. And when we see these problems, the body doesn't organize itself into the same silos medicine uses. Fatigue doesn't go to one specialist and joint instability to another. Fatigue does go to one specialist and a joint instability to another and restless leg to another. Those signals, they do in the medical system, but not for the body. The body, those signals are integrated. They come from the same source. And the osteopathic framework, one body, structure and function, reciprocally interrelated, tissue is a readable record of physiology, is exactly the right frame for reading them together.
Absolutely.
So I think we kind of covered all of our bases. So let's talk about the next episode. We're going to go into the piezoelectric story, how iron metabolism intersects with mechanosensitive ion channels, specifically piezo1, and what that means for how mechanical loading translates into structural adaptation, or fails to, which maps directly onto everything we've been discussing about across these episodes. So really how your body loads the bones, deloads the bones, how the bones respond, do they create piezoelectricity, and if they can they or can they not because of iron metabolism? Something that's going to be very interesting. Like how does your own body drive your use of iron or not drive it? So really a look into how do past injuries, and you and I do this all the time. We'll be working on something and say, oh gosh, when did you fall or when did you hurt this thing? And they go, I don't know what you're talking about. Say, no, this would have been like 20, 25 years ago. And they'll go, I did get hit by that car.
Oh, that thing.
Oh, that thing.
Yeah.
Oh, they had that one fall. I only fell off 2 stories. It really wasn't that bad. I had a really bad fall, but I'm all better from that. I had 10 surgeries. Okay. Anyway, so that'll be fun next time. I'll see you there. Thanks, Autumn, for being here. Thank you, Brent. And until
You're
then,
welcome.
All right, keep paying attention to the signals. All right, see you next time.
Thanks for joining us on another episode of OsteoSignal with Neal D. O'Neill. For more information, please visit pursuitpt.com or pursuitperformancetraining.com. Want to show your support for the podcast? Give us a like, click subscribe, and leave a comment or review. We appreciate it. Our music was written and performed by Sky Toes. Copyright 2026 by Neal D. O'Neill.